very good morning. Thanks to everyone for coming to this session. It's hard to get people just after a coffee break, so we can understand that. We're going to keep this introduction very short, but just to set the context, we all are aware of the disproportionate number of estimates that we see both for viral hepatitis B and C among people who inject drugs. We're also aware of the response that the community and researchers and different institutions have played towards addressing viral hepatitis. We have also heard from the World Health Organization on the progress and how we are not on track. Specifically, if you remember those two yellow highlights that Meg made in her presentation about the number of needle and syringes. We are at 35 against the 300 per person per year. Now, how appropriate or how relevant is that 300 is a different topic that we can discuss altogether differently. But we know that harm reduction has played a very important role in controlling HIV and also viral hepatitis. Yet, we don't see that much of a progress. We are going to talk about some of the initiatives that our community groups, institutions, and universities and researchers have done in their own settings in terms of addressing viral hepatitis among people who inject drugs. My name is Giten. I work with Treat Asia in Bangkok, Thailand, along with my colleague Judy Chang from the International Network of People Who Use Drugs. We're going to chair this session. Judy, a bit of introduction about yourself.
Sure, thanks Giten, and welcome everyone, and thank you for joining us both here and virtually. So, as Giten mentioned, I'm Judy Chang. I'm the Executive Director of the International Network of People Who Use Drugs, so we're the global peak body representing people who use drugs. And as Giten has mentioned, we're often overlooked and not able to access, comprehensive hepatitis prevention testing and treatment at the levels that we need. So in PWID, we work to protect the health and defend the rights of people who use drugs, and we work through processes of advocacy and empowerment at global, regional, and national levels. So really pleased to introduce the first speaker that we have with us today. He's Thomas Saylor. He's a scientific analyst on drug use at the Public Health Unit of EMCDDA. And he'll be presenting on monitoring viral hepatitis elimination amongst people who inject drugs in Europe.
Thank you very much for this introduction, and thanks to the organizer for giving me the opportunity to be here with you. So I have no conflict of interest to declare. And I'm going to show some data that we have put together on a tool that we call the elimination barometer. And it presents some indicators, 11 indicators, focusing specifically on people who inject drugs in Europe. And it follows the WHO framework, monitoring framework. And the data source is coming from our member states. We are working with focal points from the EU, the European Union, as well as Norway and Turkey. And we work closely with the network of the drug-related infectious disease network, and as well as ECDC, that's the European CDC based in Stockholm. So a few numbers to start with for the context, both in absolute numbers and as well as proportion. So the latest estimate of the total number of people chronically infected with HCV, and I will focus on HCV during my talk, is around 1.8 million in the EU and EEA. And we estimate that at least 35% of these infections were attributable or are attributable to injecting drug use, whether past injection or present. In terms of transmission, so the new cases, and if you look at acute HCV cases that are notified to ECDC in Europe, the latest data suggests that more than half of those are due to injecting drug use. And the total size of people who are currently injecting injecting drugs or who have done so in the last year is 500,000, or a bit more than 500,000 for the EU and Norway, which translates into a prevalence of 1.9 per thousand for our countries or our region as a whole. So looking at the barometer itself, and if you look at the impact section of the barometer, you will see that actually only one of our member states has some evidence to suggest that there's been a significant decrease in viremic prevalence among people who inject drugs. That country is Norway, and the data that you see on that slide shows a number of seroprevalence studies or serosurveys conducted among that key population. And you can see a sharp drop in the prevalence of viremic infection for HCV in that group after the introduction of universal DAA or free DAA in 2018. The red dots, the red data points are from, in particular from a study conducted in Oslo regularly every year or every 2 years, including more than 200 clients of needle and syringe programs, but also a drug consumption room. And you can see that in that particular study, prevalence of viremic infection was 46% in 2015, before the introduction of DAA. And that's actually the type of prevalence that we see in other EU countries among that key population. And it is now, if you look at the latest data in 2022, it's down to 9%, which is an 80% decrease in the prevalence of viremic infection, which was one of the WHO targets in previous WHO documents. So is Norway representative of the EU situation as a whole? The answer is no. So Norway is a relatively small country in terms of population. It's 5.5 million. The size of the population who inject drugs in the last year is around, estimated to be 8,000. And Norway is a rich country. It has a high GDP per capita number in the region. And of course, you know, having a high GDP per capita means that you are able to afford expensive medicines. But maybe a key point of the Norwegian model, so to speak, is the integrated approach that they have adopted for some years now, delivering multidisciplinary teams, or it's delivered by multidisciplinary teams in opioid clinics, opioid agonist clinics, or community centers attended by drug users. So the importance of putting harm reduction services at the core of the elimination effort was really key for the Norwegian experience. And that's also seen in countries outside the EU, such as Scotland and Iceland. This is because that's where patients can be tested, or people who use drugs can be tested, can be treated, or at least linked to care efficiently. And that's also where you can provide services to prevent reinfection. So how, that's Norway, so that's one country. How is the EU as a whole doing? Let's look at the harm reduction service implementation. So here the picture is not too bad. Our region has been implementing OAT, so opioid agonist treatment, as well as needle and syringe programs in almost all countries. There's one country, Turkey, that still doesn't have needle exchange programs or needle syringe programs. We have seen in the latest years also other types of harm reduction services being implemented, such as drug checking, take-home naloxone, and maybe more interesting for our key population, drug consumption rooms that are now available in 10 countries. But this is just showing you if those harm reduction services have been implemented. If you look at the coverage, and I will here take only one graph from the barometer, that shows the number of syringes distributed per person who inject drugs per year, latest data. And you can see that only 6 countries have reached that 2025 WHO target of 200 kits per person per year. The other countries are below that target or don't have the data to document that coverage. One note on the methodology behind those numbers. So most of those numbers are derived from programmatic data. So we divide the number of estimated number of users by the number of syringes distributed, or the other way around. The exception here on this graph is Germany, where the team at the RKI has done a really nice survey in more than 200 services, and they were able to estimate that on average 85 syringes were distributed per person per year. One note on some of the let's say right-hand side of the graph. You have countries, unfortunately, where the absolute number of syringes distributed has been going down in the recent years. That's the case for Hungary and also for Bulgaria. So we are, in a way, far from elimination, just looking at this coverage, and which I believe also shows the under coverage in terms of linking to testing and care, as was so important in the Norwegian example. There's another aspect that I would like to stress with you today, which is related specifically to the drugs market in the EU. So as you know, North America is struggling with an opioid crisis, and we are very keen to monitor the risk for the same to happen in the EU. For the moment, what we've seen is not so much an increase in opioid use and harms, but rather we're seeing a lot of cocaine being available. This graph shows you the number of the quantities of cocaine seized in the last years, and as you can see, it has hit a record height of around 300 tons of cocaine seized in 2021. And the implication of this great availability of the drug on the EU drugs market is that we're seeing, for example, that more and more people who inject drugs are using stimulants such as cocaine. The left-hand side of the slide shows results of a study that we conducted in some of the EU cities, where we collect and test for the content of used syringes. And the proportion of syringes testing for cocaine ranges as high as 72% in Dublin to 78 or 70% in Thessaloniki and Athens in Greece. And this has been, to some extent, translated in more outbreaks of HIV, which also means that HCV surely is being also transmitted at the local level, linked to stimulant injection. The latest documented one to this date is the one in Monza, in Italy, in northern Italy. Thessaloniki is not on the map. We didn't have the epic curve, but that's another one, which is it's a worrying trend, and we believe that will be a challenge for the elimination of viral hepatitis in that group because of more injection and more high-risk behavior. So recommendations and actions, what are we doing at the MCDA? We are working on getting better data. As you've seen from previous speakers, data is key and is still lacking. So we are revising our generic protocol for biobehavioral surveys among that key population, giving or taking examples from good studies that are done around Europe. We've published a guidance together with the ECDC on the latest evidence on best practice and interventions. And we're also developing with the ECDC what we call a toolkit for prisons to help putting forward good models of care that have been working in Europe in the last years, to give examples and practical experiences around Europe. So thank you for your attention, and thank you to all the contributors of this presentation and data.
Thank you. Thank you very much, Thomas. Our rest of 4 speakers were actually allotted 5 minutes. We as chairs, we have taken the discretion to give them 2 more minutes because you can't do anything in 5 minutes. That's why we kept the introduction short. So each of the speakers are going to get 7 minutes. We're going to warn you 2 minutes ahead. Please finish on time on that 7 minutes. Jody, over to you.
Okay.
to the next speaker.
Thanks, Gideon. So, yeah, thanks, Thomas, for setting the context for us here today and really getting the message out there that harm reduction should be at the core of all our efforts. Next speaker, we have Dr. Emma Poz. She's a medical doctor and infectious disease resident at Porto's Monitored Consumption Program, and she'll be presenting on lessons from a decentralized infectious disease consultation. Thanks, Emma.
Hi all. Thank you so much for being here. Thank you for the kind introduction. I'm really happy to be here and presenting this decentralized consultation because it's really the love of my life. So I have no conflicts of interest to declare. And just for context, the Overseen Consumption Room in Porto has been open since August 22. It's strategically located in Bairro da Pasteleira, which is kind of an open-air drug market. It includes many services, such as a needle exchange program, point-of-care infection screening, rooms for smoking and injecting, and also staff who can help with that, an overdose emergency kit and people who are prepared to operate it, wound care, supervision of medication, some social support, showers, and a bar. And then there are a couple of relevant protocols when it comes to infection treatment and prevention. One of those is for tuberculosis with the CDP, and the other one for HIV and viral hepatitis, which is the one I'm going to talk to you about. Also, just for reference, in the first 12 months, we've seen in the Overseen Consumption Room nearly 2,000 people. There were around 50,000 total drug users and nearly 10,000 IV drug users. So our project stands on an open door policy. We go there one afternoon a week, one infectious diseases specialist and one resident. We aim to focus on infection treatment and prevention. That included counseling, HIV PrEP, vaccination. We count also on strict collaboration with the OCR nursing staff and other staff as well, but the nurses are in charge of sample collection, patient recruitment, monitoring adherence and adhesion, supervising medication, and a lot of other important tasks. Biomedical monitoring is done at our own hospital, and antiviral treatment is also supplied by the hospital. But we do share an essential medicine stock to make sure that anyone who cannot afford proper treatment will still get access to it. We do make a point of continuously discussing our experience with the staff and also the service users to continuously improve care delivery. As to our results, so we've completed 1 year of this kind of outpatient clinic at the OCR in March this year. So far, we've seen 89 people with a median age of 43. Most were cisgender men. There were some cisgender women, and so far we've seen no gender non-conforming persons. And we were counting on doing mostly chronic infections, so HIV and viral hepatitis, but in fact, it was kind of a 50-50 split among appointments for this motive and others. Among the other motives, the most frequent was definitely skin and soft tissue infections, but we also saw a lot of respiratory infections, some trauma, some post-exposure prophylaxis, but mainly other chronic conditions in need of management, such as diabetes, hypertension, liver disease, and psychiatric conditions. Considering HIV infection, 24.1% of the people we saw were HIV positive. This includes also the appointments for other motives, so not all of these were in need of follow-up within the infectious diseases area. 90.5% of those were HCV co-infected, and within the people who were coming to us for their HIV follow-up, we had 2 new diagnoses, 5 people were treatment naive, and some of them wanted to be transferred to either our own outpatient clinic or other hospitals that were near to their houses. Among the ones that wanted to keep their follow-up in the Overseen Consumption Room, we started treatment in most of them. Sadly, we lost 2 to follow-up. And for the people who are on treatment for over 3 months, all of them are virally suppressed. We also evaluated 5 people for oral HIV PrEP, 2 of which initiated medication, but they've since stopped. Among the people we saw, 63.2% were positive for HCV antibody. Only part of them, again, were in need of follow-up. Some were transferred to an institution that they preferred, but within the ones that we kept, air quotes, 78.4 had a positive viremia, and those are either have completed treatment, are ongoing treatment, or waiting for treatment. except 6 that we've lost to follow-up, and sadly 1 that has died of squamous cell carcinoma awaiting treatment. So what are the lessons? I really am in no position to teach anyone anything, but I wanted to reflect on what we expected from this project and what we found. There are many, many, many other reflections that we could talk about here, but focusing on the infectious part, we were hoping to focus on chronic infection treatment and prevention, but what we found was really complex and variable health needs that included chronic illness, mental health, sexual and reproductive health, which we still need to address. We were expecting frequent loss to follow-up, also low adherence and poor disease-related outcomes, but this turned out not to be the case. And we were expecting some HIV PrEP engagement, but turns out that the uptake was very low and we could find no maintenance beyond 3 months. So I'd like to thank all the people that use the OCR in Porto and who've trusted with us with their health and their life stories, the whole teams from the OCR, but also from my own department in San Antonio, and all the activists in Portugal who've been pushing for harm reduction for over 2 decades. Thank you.
Thank you so much, Emma, and for really demonstrating, not only how important harm reduction is, but, really community priority interventions such as drug consumption rooms. They're really important to be able to reach the most marginalized and, in doing so, being able to better understand, the context, the burden amongst the community, but of course also in progressing us towards hepatitis C elimination and really trying to reach that last mile as well. So our third speaker, we have Dr. Brian Conway, an infectious disease specialist known for developing innovative HIV and hepatitis C programs, particularly for inner city populations and people who use and inject drugs. So today he'll be sharing information on the community pop-up clinic in Vancouver. Thank you.
Thank you. It's a pleasure to be with you here today to talk about an innovative model, the goal of which is to engage vulnerable inner city populations in multidisciplinary care, and in so doing, increase uptake of HCV treatment. And this structure is called the Community Pop-Up Clinic. And these are my disclosures as well as my affiliations. So we think in Canada we have about 172,000 drug users, about 35 to 40% of whom are infected with hepatitis C. So 65,000 is a good ballpark figure. In this meta-analysis presented at INSHU last year by the Australian group, we again say that we have 35% of the population that is infected. We've done a great job of diagnosing them. We're at about 75 or 80%, as shown on the left side of the slide. A less good job at engaging them in treatment. We're down at about 10 or 15%. So this is really a challenge for us to address. In my inner city of Vancouver, there is, to say the least, an adversarial relationship between the residents of the inner city and the established authorities, be they legal authorities, governmental authorities, or even within the healthcare system. And if we're going to get anywhere, we need to break down these barriers, be they literal fences or anything else, to create this sense of engagement so that we can really improve the health and well-being of this key priority population. So what we developed is a tool called the Community Pop-Up Clinic. This is held at single-room occupancy dwellings, the houses where people live in the inner city. It is held once a week. We will see on average 30 individuals per session. We will offer point-of-care testing for HIV and hepatitis C, an immediate on-site consultation with a physician or nurse if there is a need for some intervention, and engagement in multidisciplinary care that we refer to as a four-legged chair. We think of people as having medical needs, social needs, addiction-related needs, and mental health needs. And unless we address them in context and in the order that is most important to the individual that is before us, we will never get to hepatitis C treatment. And that's really the process of engagement. So individuals will show up, they'll provide consent, we'll we'll collect demographic and other information that I'll share with you. We'll do point of care testing, and if it's negative, they still get the $10 Canadian gift card for having participated, and we will still engage them in some discussion around what could be some of their other needs. If they're positive and they don't want to see us right then and there, I know where you live, and I will be back, and we will continue a discussion on your terms to produce the level of engagement that I feel would help you. And if you want to be engaged, we do so right there on the spot. They can be seen at the clinic downtown, at the new inner city clinic, or we have a medical van that goes around. So over 20 months, we conducted 112 events, about 18 people per event, saw 2,000 people. The majority completed the demographic questionnaire, 31% HCV antibody positive, 474 RNA positive, the majority of whom engaged in care. So for each hour we operate, we engage one person in HCV treatment. So it's a very powerful tool. Demographics are interesting. Average age 45, 35% female, 32% indigenous. And I'm showing you the educational characteristics of this population because one of our goals is to break down the them and us barriers. They are us. Look, they've gone to high school. Some of them have gone to college. They're not so different from you. So it's not them and us. It really is us and us. So 387 people engaged in care. 326 started treatment. One died of an overdose pre-treatment. The others in this analysis haven't started treatment yet. Of the 326, 304 have completed treatment. Only 3 lost to follow-up, an additional unfortunate death. And of the 304 that completed treatment, 286 out of 288 in whom we have an outcome acute, 99%. We don't lose people. We keep them in care and we cure them of their hepatitis C, in addition to addressing some of their other needs, which would be the subject of another presentation. So where does this scale up? It scales up to elimination. So the World Health Organization wants us to do this by 2030. We can do this in 3 years. We think there are 1,200 untreated people in our environment. We can diagnose 90% of them in 3 years. If we treat 25 to 28 per month, well within our ability to perform, we will have reached the treatment threshold, and we will be left with an inner city that is relatively free of HCV infection. So we need to accomplish the goals by 2030. This is a population in whom we need to have a conversation. It isn't about Hep C, it's about engagement. It needs to be multidisciplinary, and this is an ambitious but achievable goal. 2 things that have to be done. The first is, it's not them, it's us. Us is us. We're helping ourselves get out of a situation that is a public health emergency. We're not helping a population that is foreign to us, and you have to have lots of partners, political partners, community partners, commercial partners, pharma partners, if you are to accomplish this goal. And we're very proud of the CPC program, and hopefully in 3 years I'll be back here to tell you we've wiped out hepatitis C in Vancouver's inner city. Thank you.
Thank you, Dr. Brian Conway. So we moved from Europe to Canada, which, as you know, as we all know, is in the middle of an overdose crisis. We saw how important pop-up clinics were for overdose prevention. There was a lot of media coverage on that. So thank you for sharing, how these innovative models, such as pop-up clinics, can be used to amplify and scale up hepatitis C screening testing and engaging people who inject drugs for treatment. So next we have Mercy Nyakowar from Kenya. She's the viral hepatitis lead for the people who use drugs and people who inject drugs at the National AIDS and STI Control Program with the Kenyan Ministry of Health. So thank you, Mercy.
Thank you for the organizers of this conference to just allow me to present on the hepatitis C and hepatitis B prevalence and risk factors among the people who inject drugs in Kenya. I'll be following through their format below. And I just want to acknowledge all the people who inject drugs in Kenya, as well as the peer navigators who've been very helpful while conducting this research. The following are my disclosures. Specifically for this study, we've been looking at and trying to assess the factors associated with hepatitis C antibody as well as hepatitis B positivity among the people who inject drugs in Kenya. We are all aware that injecting drug use is one of the important risk factors for viral hepatitis in sub-Saharan Africa. And it's important to just understand the factors associated with seropositivity so that we are able to also minimize the risk of transmission, as well as also building programs that are able to prevent the incidence and prevalence among the people who inject drugs. For this survey, we are working with harm reduction centers across the country to enumerate people who inject drugs up to a number of 3,500, and you're enumerating the people who inject drugs using the respondent-driven sampling, where participants go through biobehavioral survey and also receive hepatitis B, HIV, and hepatitis C testing. The data was analyzed using chi-square test for the categorical variables and also t-test for the continuous variables. Our results are as follows. Out of the 2,135 participants enrolled between May 2022 and August 2023, majority are male, and the average age is 34.6 years. When you look at the hepatitis C prevalence by region, we are seeing graduation from coast towards the western region, with the prevalence being high in coast, followed by the central region, basically at the capital city, Nairobi, and the lowest prevalence in the western region. Same to hepatitis B. We see the prevalence being high in western region, followed by Nairobi, and last in the coastal region. So the same with results. When we look at the HCV positivity, we are seeing that female are significantly more likely to be positive than male. And also they have a higher prevalence of hepatitis C compared to men. But when it comes to hepatitis B positivity, there is no statistically significant difference between the female and the male PWIDs. We also look at the risk factors associated with HCV and hepatitis B positivity. And in the risk factors, we noticed that all factors in the table are significantly associated with HCV positivity, with strong association between reused needles, reused cookers, and previous incarceration, in addition to years of injection. Only reusing needles and cookers was significantly associated with hepatitis B positivity. So in conclusion, we say that viral hepatitis prevalence and risk factors, such as shared injection equipment, suggest a need to expand harm reduction intervention. And we acknowledge that there are different risk factors for hepatitis C and hepatitis B. And it's important to just know that there's no one size that fits all interventions that may be optimal, and hence we need to vary our approaches in terms of ensuring that female and injustice-involved PWIDs are reached out with viral hepatitis-related interventions. Again, we say that while primarily we anticipate that the data will inform policymakers and programs on identifying viral hepatitis elimination and prevention strategies among the people who inject drugs. So for future directions, we are going to perform next-generation sequencing and phylogenetics analysis to characterize transmission networks and determine factors associated with transmission and cluster membership. We are going to just leverage these for targeted elimination strategies to reduce viral hepatitis among the people who inject drugs. And potentially, we are going to generalize to other resource-limited settings. I just want to acknowledge the Ministry of Health where I work, in addition to the funders, which is NIH and NIDA, and also Albert Stein Global Health Center, and the NSP implementers, which we work with to just reach out to the people who inject drugs in Kenya, that is Sub-Tanoset and in Coast region, as well as the Western region, in addition to the collaborating laboratories that are facilitating the testing and also the PCR. So this is the team that is doing this work at NASCOP level. Thank you so much.
Thank you so much. Our next speaker is going to be Mr. Rajkumar Nalinikanta from Manipur, India. Nalinikanta is president of Community Network for Empowerment. It's a network of people who inject drugs and have been working on viral hepatitis for more than a decade. And their work has been profiled as one of the best practices by WHO. And their other abstracts has been selected as best abstracts in symposia related to PWID and HIV and hepatitis work. Kanta.
Thank you very much, Chair, for your kind introductions. Thank you, organizer, for having me here. And thank you, everyone out here, for your time to attend these sessions. So let me just begin by giving you a background about our organization. CON stands for Community Network for Empowerment, which is a drug users network of 10 community-based organizations of people who use drug based in Manipur, India, and it was established in 2011. To give you a further background, a little bit on the genesis of hepatitis B vaccination initiative. In 2012, WHO recommended rapid regimen schedule of 0, 7, and 21 days for hepatitis B vaccinations. However, the national program in India do not follow this schedule. Rather, they follow the standard schedule of 0, 1, and 6 months. But the compliance rate of 0, 1, and 6 months among people who inject drug is very challenging. So besides WHO, various recommendations has also been made for hepatitis B vaccination among high-risk group by Global Fund as well as the US CDC. So based upon the genesis mentioned above, as a demonstration, CON offer hepatitis B vaccination to 677 PWID and PLHIV using rapid regimen. In terms, going on to how we have done in terms of the method that we are involved to understand the efficacy of the rapid regimen. During a period of October 2017 to August 2022, 677 PWID and PLHIV were completed 3 doses of standard 1 ml hepatitis B vaccination. Out of 55% of these 677 PWID were identified for anti-HBs test. Blood samples were collected from the participant by the peer from among the PWID community, and after an interval of 1 to 5 years from first dose, we stored the blood sample at Babina Diagnostic Center, and the sample was transported to a centralized laboratory in a phased manner for anti-HBs tests. In terms of the outcome, as I have also mentioned in my previous slide, that the total number of people whom we have vaccinated were 677. So we noticed 100% of the participants were compliant to the full 3 doses. 55% of them were provided anti-HBs tests, out of which 85% of them were found to develop immunity with anti-HBs titer more than 10 IU per ml, and the remaining 15% of them were found anti-HBs titer less than 10 IU per ml. This slide is to give you more in details about those 56% whose anti-HBs titer were less than 10 IU per ml. In between the process, 6 participants out of 56 were not able to trace when we tried to reach them out for a booster dose. So altogether, booster dose was administered to 50 of them, among which 86% of them were found to be at the protection level, and the remaining 14% were found with anti-HBs titer less than 10 IU per ml. In conclusion, to summarize the above to make it clearer for everyone, 21 days rapid vaccination with standard dose is feasible among people living with HIV and people who inject drug. We noticed 100% compliance to the vaccine schedule, 85% with anti-HBs seroprotections without booster dose, 86 with anti-HBs seroprotections with booster dose. So therefore, for PLHIV and other high-risk group, rapid regimen of hepatitis B vaccination may be an effective public health strategy to control the new infections. Lastly, I would like to acknowledge the following for their contribution to make this program success. I would like to thank all the staff of my organization who have been involved in the process from the beginning till the completions. I would also like to thank Street Asia and for Bangkok for providing us the technical support. I would also like to thank Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow, India, for their pro bono anti-HBs testing. And also, I would like to thank Babina Diagnostic for providing sample storage space. And lastly, but not the least, I would also like to thank South and Southeast Asia platform for their financial support to enable me to attend this summit. Thank you so much for your patience.
Thank you. Thank you very much, Kanta. Hepatitis B and rapid regimen, this has been talked for quite a bit of time. It's good to see some results here from your end. We can debate on whether or not hepatitis B vaccination among adults is required or not, but I don't think we will have the time to do that for us here. But thanks for bringing this very important subject up and showing us some results. That's 88% responding without a booster dose. I think that's, from a public health approach, very much acceptable results. We are now going to be opening. We have around 15 minutes for question and answer. I'm monitoring if there is anything online. We don't see anything online as questions. If anyone has questions to the panel, do we have microphones? Yes, we have people with microphones there, so please raise your hands or walk up somewhere where they can access you to raise your questions. Remaining 3 minutes, Judy will take that for the closing of the session. Anyone there? Okay, please. Yeah.
Hi, thank you all for your presentations. This question's for Dr. Conway. You talked about if a patient isn't ready to get tested for Hep C when you're there, that you know where they live and you go and find them. Could you talk a little more about that process?
Yeah, I think the whole program is based on engagement. And it's on the terms of the individual with whom we're dealing on that particular day. So if they don't want to talk about Hep C, they don't want to be tested for hepatitis C, they may want other things, government forms filled out, access to addiction care, access to housing forms. So we will note that we have collected information on them with respect to Hep C, address the other needs, and try to identify an opportunity in the future to double back and deal with the Hep C. So it really is an ongoing collaboration based on engagement.
Hello, thank you for your presentations as well. This question is for Dr. Emma. You were talking about how you were providing, of course, treatment, and you had some loss or follow-up, and also some people discontinuing treatment prep-wise, as I remember. What are the main challenges for avoid this, the loss of follow-up? Because we've been seeing that, at least in our experience at GAT in Lisbon, we've been seeing that in order to reduce that, we need to invest a lot in follow-up projects with peers, peer-leading projects that go with people to treatment, and they, go find people in the city so they can, offer them the treatment that they are doing already. But this is very expensive and we are not having a lot of support. So is this your case? How could we improve this situation? Thank you.
Can you hear me? Yeah. I completely agree. We have the same issue. So we have in the OCR one peer worker who has so many tasks at hand, so they can help somewhat finding the people to bring them back, but it's not enough. We would need to have a bigger network of peers to navigate the city and possibly engaging peers from different cities, because another big issue is mobility within cities, because most lost to follow-ups are actually people who moved from Porto to Leiria or Porto to Coimbra, where there isn't a service that we can reach to make sure that they are followed there. So I completely agree with the criticism that we don't have enough peers and we'll need a lot more investment on that.
Hello, everyone. Thank you so much for the presentation. I look forward to connecting with Dr. Emma and Dr. Conway for their support. I'm from Sierra Leone. We're now suffering. The government has actually announced the use or the abuse of kush as a public health crisis currently. So it's killing the youths on a daily basis, and you will see people in the streets addicted, and they are almost unconscious in the streets, and it includes also students. So the youths are actually being taken away from us in Sierra Leone, unfortunately. So it makes me also wonder, and I'm really interested in Kenya, what kind of drugs they are taking, the injectable drugs, because for Sierra Leone, the youths or people are not injecting drugs, but they are taking the K2 spice, which is a synthetic marijuana. So I really count on your support to learn from you about your projects that you've implemented that could also be, that could possibly be feasible to be implemented. I really count on your support. Thank you.
Would you like to respond, Mercy?
Thank you.
It should work.
Thank you. To just respond to the type of drugs people use in Kenya, they do inject heroin.
Thank you. And I think you should catch up after the session. And I think the session is never enough. So connections like this are important if what Mercy has talked about is going to help some people and fellow people who inject drugs or use drugs in Sierra Leone. Please make that connection. I think that's why we are here. That's why we need the networking for. That's why we need these kind of summits for. Thank you for raising that, and please establish contact after the session. I don't see any more hands, so all right. So then I would hand over to, we're right on time, bang on time. I'd hand over to Judy back for the closing remarks.
Thank you, Gideon. So yes, just to reflect on some key takeaways from the session, I think a central message was really how important harm reduction is to hepatitis elimination efforts, but not only for prevention, but also, as we heard from the speakers, research, public health surveillance, screening, testing, diagnosis, and engaging people in treatment. As a woman who uses drugs, harm reduction has really, been my entry point into wider health services. And, I think from all the interventions that we heard about, we definitely saw this. And yet, when we look at, the figures, globally, only 2% of people who inject drugs, live in countries where there's actually sufficient and high coverage of harm reduction services. So we know that we all have to do better. And, it's not only, of course, about the interventions, or to even get there, we need to be addressing criminalization, stigma, and discrimination, as the central barriers. As we also heard from the panel, grassroots and, very kind of simple interventions, make a huge difference, especially to the most marginalized. We heard that, free treatment in Norway led to a very rapid decline, in incidence. Drug consumption rooms are a very, very key intervention in increasing, access to testing and treatment. And yet, as far as I know, there are no countries in sub-Saharan Africa, Eastern Europe, also Asia Pacific, that actually have drug consumption rooms at present. We saw how important also innovative models such as pop-up clinics, but also, community-led interventions and peer leaderships. They're really central to enabling trust and, of course, access. Always I think a central message is we really need to meet people where they are at. We talk a lot about the last mile in universal health coverage. People who inject drugs, people who use drugs, we are that last mile. And in the name of equity, in hepatitis elimination, we really need to really work at putting the last mile first. So thanks to Gideon as my co-chair. Thank you to Emma, Brian, Mary, Thomas, and Nalinkanta for their excellent kind of interventions and presentations. And thank you to the audience also for being here.
Thank you all. Please feel free to connect with all the speakers, as I said again, and thank you for being here.